Hello, my name is Zita Aborbekson. I'm a first-year internal medicine and pediatrics resident at the University of Illinois College of Medicine in Peoria. I worked with second-year internal medicine resident Rose Chisinga to present to you all a case of cutaneous blastomycosis mimicking breast malignancy. Blastomycosis is an infection caused by the fungus Blastomyces dermatitis, which can be seen histologically in Figure 3 of this poster. This fungus is typically found in the Midwestern region of the United States and is commonly associated with pulmonary infections. However, it can affect multiple organs, resulting in extrapulmonary manifestations in both immunocompetent and immunocompromised individuals. In this case, we cared for a 50-year-old female from Illinois who came to us with 1 year of a progressively worsening left-sided breast lesion that initially began as a small nodule 1 year prior. She had a past medical history that was significant for type 2 diabetes, as well as morbid obesity. She also had a family history significant for breast malignancy. A review of symptoms, including fevers, chills, pulmonary symptoms, night sweats, and weight loss, were all found to be negative. She was trialed with topical antibiotics and oral antibiotics as an outpatient, but did not experience improvement in her symptoms. Figure 1 depicts the lesion 1 month after initial presentation, while Figure 2 depicts the lesion at the time of admission. As can be seen, the lesion occupies over half of her breast, is raised with an irregular necrotic border, and is erythematous. She had foul-smelling purulent drainage at the site, but had no breast nodularity or any evidence of lymphadenopathy. She had additional workup with CBC, a CMP, inflammatory markers, fungal antibodies, and blood cultures, all of which were found to be negative. She had mammography, which showed the lesion to be confined to the skin without deep tissue invasion. She also had a core biopsy that revealed a diagnosis of blastomycosis with no evidence of malignancy. Additional tissue and fungal cultures were positive for MSSA as well as Klebsiella. She had a CT chest that showed no evidence of pulmonary infection at the time. A final diagnosis was made of left breast cutaneous blastomycosis with superimposed bacterial infection, for which she was treated with amphotericin and discharged home on itraconazole as well as Augmentin. Upon 2-month follow-up with the infectious disease clinic, she showed significant improvement in the size of the lesion. Pulmonary blastomycosis is the most common cause or presentation of blastomycosis infection. However, as seen in this case, extrapulmonary manifestations such as cutaneous blastomycosis are also common. A majority of extrapulmonary cases of blastomycosis are thought to occur via primary pulmonary inoculation and subsequent lymphohematogenous spread. Cutaneous inoculation is extremely rare. Despite this, most individuals with extrapulmonary presentation have no history of pulmonary disease and have no CT findings or additional imaging findings suggesting of pulmonary disease. As a result, it is easy for blastomycosis to mimic multiple pathologies, such as neoplasia, as in this case, rheumatologic disorders, and other infections. This makes the identification of blastomycosis infection without pulmonary symptoms to be particularly difficult. This case stresses the importance of keeping a low threshold of suspicion for cutaneous blastomycosis, particularly in individuals in endemic areas. Furthermore, it shows the importance of prompt tissue biopsying and culturing in order to prevent delayed treatment. Thank you very much for your time.